everyone, so this is the Chapter 3 lecture for our Medic 237, or if you're taking this course with me at Solano, it is the OT61 course. We are talking today about managed care contracts. We start with talking about the provider compensation and how our providers are paid when dealing with managed care contracts. So the managed care contract is a legal document between a healthcare provider of some sort and an insurer. So that provider could be a hospital, a clinic, a physician, some sort of provider and of healthcare services, and an insurer. There's an insurance company, an insurance carrier, an insurance plan, whatever you want to call it, it is an insurer. The provider then agrees to discount the UCR fees in exchange for more patients. And so what happens here is the provider says, okay, I will sign up and go into a contract with this managed care organization, and in doing so I will become a part of this network, and that will allow the managed care organization to funnel more patients to me because I'm part of the network, and I will have an increase in patient load and therefore make more money, and so I can afford to discount my usual and customary and reasonable fees. And so that's kind of how that works out. So the contracts between hospitals, clinics, and physicians create the network for the policy holders to visit, and this same network then is also utilized by the providers when they are providing referrals, and that helps to keep the cost down for both the patient and the carrier. So some important terms down here that you need to know. The provider that signs the contract is known as the PAR, that is the participating provider. A provider who is not under contract is known as a non-PAR, and that is a non-participating provider. And those non-PARs are out of network and out of plan, which means that they will receive a lower amount of compensation on charged services. So participating providers will receive a higher rate of reimbursement. Non-PARs will receive a lower rate of reimbursement. So some things to remember there. So if you're wondering why it's important to know these things, you should know that it is especially important that you, as the medical assistant in our case, or the medical office specialist, or the biller, whoever it is that is handling the billing and compensation for the office, needs to understand the compensation and billing guidelines. These guidelines will often vary plan to plan. If the proper billing procedures aren't followed, it will delay the compensation for the provider, and that ultimately delays the income for the office. So that is a big deal. It's important that you understand how and when the provider is to be paid, what type of payment that they are supposed to be receiving, any provisions and limitations, and then any type of amendments for compensation. So those are all important things that you need to note if you plan to be doing billing on a pretty consistent basis, because those are all things that are going to heavily impact how the provider is going to be compensated. So they are also things that can wrap a person up into fraud or abuse claims if they are not followed correctly, and those are not anything that anybody wants to be wrapped up in. So we'll talk about that a little bit more later on. So I'm going to blow this up over here. The key elements of contracts are another set of points that you need to know. So these are the requirements for claim submission and reimbursement. There's the schedule of benefits, and that is all the list of covered services. So when you take out an insurance plan, or when you become a member of an insurance plan, one of the lists that they give you is called a certificate of coverage, or a schedule of benefits. And so you have this a whole list of covered services that is one of the sections of this managed care contract, and it is all of the things that the contract says that they will pay for when a covered member has them performed. And so if a member comes in and they have an office visit done, or they come in for an office visit, that's a covered service, or they come in and they have a throat swab done, that's a covered service, or they have a hysterectomy done, that's a covered service, or whatever the case may be. But then there are other things that are excluded from that schedule of benefits. For example, most cosmetic services. So say a patient comes in and they say, I would like to have a rhinoplasty done for cosmetic purposes. So they want to have a nose job done because they simply don't like the bridge of their nose. That would be an excluded service. Or I want to have a liposuction done because, well, I've had a lot of babies and I no longer like my stomach. And that is a fact for me, I would just like to point out. My insurance will not cover me having liposuction done because I really like tacos and I've had a lot of kids. So it is not medically necessary, which we're going to get to in a little bit. Actually, we talked about medical necessity in the last lecture. If it's not medically necessary, it will probably be excluded from the schedule of benefits. So that is an important list. It's all the list of covered services. The second point is a description of providers' compensation for those services in the schedule of benefits and the payment method, whether it's going to be a discounted fee for service, whether it's per diem, per case, a percentage premium, or a capitation payment. The third point is a time frame for claims submission and the payment of claims. So how long it is that we can expect to be paid for those things, and how much and how when we can be paid for them. Requirements for claim submission, such as the time limits for submission and the forms or electronic format to be used. So do we only have 30 days to submit those claims after the procedure has been performed? Do we have 6 months to submit those claims after the procedure has been performed? Things like that. Coordination of benefits requirements. We're going to talk about coordination of benefits in a couple of slides, so we'll talk about that a little bit more in a few minutes. The terms regarding late payments and any penalties or interest charges, any restrictions or guidelines in regard to seeking payment from members, and then lastly, the terms for changes to the fee schedule. So all of those things have to be required for claim submission and reimbursement. And they all affect how the provider is compensated. Okay, let me zoom back out here. So, the next part of the managed care contract, I'm going to blow this up here again, is the covered services. So all managed care contracts have a section called that schedule of benefits, like we were talking about, that lists all the services that are covered under the plan. It should include what is preventative, what procedure is capitated, and then any CPT codes and rates for each procedure. So it will look different for the billing specialist or the medical assistant who is working on the office side of things, but I wanted to show you what that will look like for a member of an insurance plan. I pulled up my Anthem one, so I have Anthem Blue Cross, I have an HMO plan, and Anthem does a pretty good job. I'm sure Kaiser does as well, and other insurance plans. But to find a schedule of benefits and what it typically looks like, you can pull up, and on Anthem it's just, it's all laid out for members as well as providers. So you just click Find Benefits, and you can search things here or by letter down here at the bottom. So say I wanted to find out what benefits I had for an MRI, and if I wanted to go for diagnostic imaging, then I could do at a facility, and it would tell me I can view details about my share of the costs for related benefits using the links below. So for radiology and x-ray, my share of the costs, if I use an in-network provider, is covered in full. If I go out of network, it's not covered at all. If I use an outpatient hospital, If it is in-network, I'm covered in full. If I use an out-network provider, then out-of-network provider, then I'm not covered at all. So again, here's like a mammogram. I have a copay for mammogram. My mammogram copays are $15 if I have co-insurance. So if I had an 80/20 plan, I would have to pay like 20% of the charge of the mammogram. If I had a deductible, then that would apply towards that. Those different things. So if you wanted to find out like what types of deductibles or anything like that you have, then you can always find out those things. People can always find out those things too. So like our family has a $3,000 annual out-of-pocket maximum each year. So the maximum that we will pay out of pocket each year is $3,000, and then our insurance will cover 100% of everything. Just different things. Also too, when you're looking at benefits, it has some of them will have acupuncture, like your benefits listed for you as well. So like Anthem, I said on the Find Benefits Schedule Benefits tab will have just a quick rundown. So you can have like it shows that we have acupuncture, breast pump, chiropractor, those types of things, home health aid, inpatient dental. It doesn't cover any outpatient dental, so don't like cleanings or anything, but inpatient dental if there was any dental work done as a result of like a car accident or anything, so dental work that was done inside of a hospital, transgender surgery, skilled nursing, things like that. So, and then for anything that you can't find, you can usually go on to a insurance plan's website and find a medical certificate booklet, and that will give you the full rundown of specifics for coverage for a plan. So even if this is not for your plan, if you're looking this up for a patient, you can go, if you can get access to the website for that patient's plan, you can usually get their certificate of coverage, and this is where you will find full access to the plan. So and these are usually commonly listed because they are pretty public knowledge, and so this is where you will find details about everything. So for example, here, if I was receiving general medical care in a non-hospital based facility, if I was getting hemodialysis treatment, including treatment at home, if okayed by the medical group, I would have a $15 copay. No charge for medical social services, $15 copay for chemotherapy, $15 copay for radiation, $15 for infusion. So I mean, it just goes on and on and on. So these are the details under the medical certificate coverage for each plan's specific charges. So you can find information, all kinds of information, on a lot of the insurance plans websites. So always a good idea to check out there too. All right, so back over to the lecture. The MA should also be aware of who handles the coordination of benefits at each managed care company, because that is who you're going to call with reimbursement questions. So if you're having trouble with reimbursement issues, or being compensated for services that were provided, the benefit coordinator is going to be, or the coordination of benefits person is going to be who you're going to call to get those resolved. It is of utmost importance that you have thorough knowledge of the payment structure, the fee schedules, the payment dates, capitation policies, all of that for the various managed care contracts that you're working with at your office, because those are going to affect how you get paid as well. Okay, whoa, I went too far, sorry about that. So the next section is ethical standards, and if you don't know, ethics are the rules that govern people in general, but in this case, the conduct of most professions. So the healthcare profession is definitely chock full of ethical standards. There are legal standards, and then there are ethical standards which govern the way we behave. And so the necessity of changes in healthcare financing and delivery has been widely accepted. I mean, it's been widely accepted that, you know, we can't continue to provide care without changing the way that we finance that care and the way that we deliver that care. But that has not been without issues, because we have all these corporate business values of efficiency and cost reduction and inventory management and competition and profits to be made. And all of those corporate business values have kind of replaced the traditional medical ethics and values in the doctor and patient relationship. So, you know, before, years ago, the doctor-patient relationship was based on providing care and holistic and humanistic interactions, and there wasn't a lot of thought behind cost reduction and inventory management and profitability between the patient and doctor relationship. And unfortunately, these corporate business values have kind of come in and taken hold, and now those are all forefront and center in the healthcare system. So the healthcare system realistically can no longer accommodate the unlimited demand for medical services, and the reality is that cost matters as much as access to and the quality of healthcare being delivered. So the result is that the lines between business and medical ethics and values have become blurred. And so it is of utmost importance that we, as healthcare professionals and healthcare team members, help maintain clear ethical standards, and that we help our providers maintain clear ethical standards when it comes to dealings with compensation and managed care contracts and billing. So we want to make sure that we are not committing any fraudulent activities, and that we are not upcoding or downcoding, which you'll learn about later on, or that we're not billing for things that are unnecessary or anything like that. The managed care organization evaluates providers' credentials to determine if they can provide the care that is required by the managed care organization. So the thing is that the provider may not be the best provider in the area, but they may be the only one who was willing to sign with the managed care organization. So if you have 5 OBGYNs in the area and one certain zip code, then you know, the one who signed with the managed care organization may not be the best one. You may have 4 better OBGYNs, and it just so happens that, you know, the 5th one was the one who signed, and now that's the one who's in network, and that's the one who everybody who is a member of that network has to go to. And unfortunately, that's the nature of the beast. So it doesn't mean that the provider who signed is the best one. It just means that that's the one who people have to go to now, because they are the one in network, and that's the one who's getting the bills paid the most. So that is a little bit of an unfortunate circumstance, that just because they are in network doesn't mean that they are necessarily getting the best quality of care, but it does mean that they are getting a more affordable line of care. Medical assistant, and it does mean that they are at least getting verified care, because managed care organizations will not contract with anybody who doesn't have verified credentials and that they have deemed to be able to provide care required by that organization. So it's not like they're hiring people who aren't qualified to care for patients. It just means that they may not be, like, you know, top of class people. The medical assistant should follow the legal guidelines exactly to prevent unethical or fraudulent behavior, and always, always, always refuse illegal behaviors, no matter how tempting it may be. You should definitely not ever engage in any of that mess, because even though the provider can be prosecuted, the person who committed those acts, aka you, can also be prosecuted for fraudulent and illegal behaviors, even if you committed them on behalf of the provider. So if you committed fraudulent billing, then you can be prosecuted for that as well. Alright, so I keep flipping back. The Last section on page 2 is Concierge and ACO contracts. So you should know the difference between the ACO and a Concierge contract. The ACO contract is a Medicare shared savings program, and it is in place in order to provide coordinated care among providers. The Concierge contracts do not require deductibles, coinsurance, or copays. And both of these have physicians that are non-participating in any health insurance, including Medicare. So even though the ACO is a Medicare shared savings program, its physicians are non-pars in Medicare. Kind of crazy. How it works, though, is that there is an annual fee paid by the patient, and that fee amount was agreed upon by the patient and the provider. And so here's the thing that we know. We know that healthcare is super expensive, and that we are constantly coming up with creative ways to try to reduce those costs. And these two types of contracts are examples, excellent examples, of creative ways to reduce the cost to the patient and to be able to pay the provider a fair market reimbursement for their services and still get the patient the quality care that they deserve and that they are seeking. And so the patients don't have insurance, and they are able to see a quality physician of their choice, and the physicians are getting paid a fair market rate, but it's all being hashed out between the physician and the patient. So there's not really any insurance company involved. It's all just sort of getting worked out old school between the doctor and the patient. So that's the deal with ACO and concierge contracts. All right, so page 3 has a whole bunch of contract terminology on it. You can read through all of these. I think there's a whole section. It's Learning Objective 3.5 in your textbook. You need to know all of these. The payer, the emergency services, participating provider, covered services, benefit plan, contracted services, covered person, urgent care. Urgent care is a walk-in clinic for illnesses that require immediate but not emergent care. That is a big difference between emergency services, which are for injury or sudden onset illnesses that places a covered person's health in serious jeopardy. So people confuse urgent and emergent services a lot, and people use emergency rooms as urgent care facilities and primary care services quite frequently, especially when they are under or uninsured. So make sure you know the difference between those. Medical directors, co-pays, fee maximums, medical necessity, participating hospital. And then this last one down here, contracted services. I don't know if I said that one or not, but and then this last one down here, coordination of benefits. There's one note I want to make here. Coordination of benefits is abbreviated COB. It is the determination of which of two or more health plans will provide benefits as the primary or secondary payer when a patient is covered by multiple plans. So there's something called the birthday rule with coordination of benefits, and I don't know if this was mentioned in your PowerPoint lecture someplace or in the reading material, but it is something that I want you to know. So with the coordination of benefits, say you have a mom and a dad who have, or two parents, mom and a dad and a dad, whoever it is, if a child is insured by more than one health insurance plan, okay? And the kid has a plan with both parents, and so he goes to the doctor, and it's great. The kid has double insurance, and you need to figure out how to coordinate those benefits so that there shouldn't be any copays. If he has double insurance, then there shouldn't be any copays. There should be nothing out of pocket for the parent, okay? So the way that the birthday rule works is it states that whoever's birthday comes in the calendar year first, will be the primary insurance. So for example, for our children, if they have insurance through me and insurance through my husband, my birthday is in May, my husband's birthday is in December. My insurance will always be primary because my birthday is in May. My husband's insurance will always be secondary because his birthday is in December. So my insurance will pay everything first. His insurance will come through as secondary and pick up everything that my insurance did not pay, ideally, and be the secondary payer. So that's how the birthday rule works. If it so happens that both parties providing insurance have the exact same birthday and month, then it goes to year. And so if they were born on the same birthday, month, and year, then it's whichever, I think it's whichever policy went into effect first, I think is the rule. But generally, that's so rare that it doesn't happen very often. But with the birthday rule, it's whichever birth month whichever policy holder's birth month is first in the calendar year. So just remember that. All right, and then the last page of this lecture is the patient's bill of rights. Make sure you know all of these things too. I got lazy and didn't feel like writing them out, so I copied and pasted them into here. The providers and the managed care organizations must abide by both the patient bill of rights and the additional consumer protections that were dictated by the Affordable Care Act, and that's what's pasted in here. So the Affordable Care Act mandated all of these additional consumer protections, some of which include bans on discriminating against patients with pre-existing conditions, dropping coverage due to application errors, lifetime coverage limits, limiting the choice of doctors within networks, and then restricting ER care. All of those in that first bullet point, those are huge changes. So we had talked about the pre-existing conditions before. That was a huge deal. But that dropping coverage due to application errors, that was also a big deal. So it used to be back in the day before these ACA consumer protections came about, people would have their insurance, their healthcare coverage, their insurance coverage dropped for the dumbest stuff. So if they had the tiniest little application error on their healthcare application, like when they were applying to take out health insurance, they would have their application dropped, or they would just not get health insurance, and they wouldn't be able to take out health insurance again until the next open enrollment period. And so it could be a whole nother year before they could apply to take out health insurance again. So people were largely uninsured for a whole entire year. I mean, maybe even their whole family. So if that happened to me and 6 other people would be uninsured for an entire year in our household over an application error. So they did away with that rule. Which was nice. Lifetime coverage limits, that was also nice that they did away with those. For instance, on people who have very high dollar treatment, for example, cancers, or those who need long-term care facilities, those get very expensive very quickly. And so before, an insurance may cap out at like $1 million of lifetime treatment, and they did away with that because it is not hard to reach $1 million when you have a metastasizing cancer that requires treatment. So that's not hard to do in a matter of a year, especially in California. So they did away with those lifetime coverage limits. That's really cool. And then limiting of the choice of doctors within networks, they did that. And then restricting ER care, they also did away with that. They gave patients the right of appeal. They gave them the right to information disclosure and confidentiality of health information. They gave the right to respect and non-discrimination, which was really cool. They also gave certain preventative care available at no cost. For example, free birth control. Birth control became free. Everything from pills to IUDs became free with these provisions to the ACA. Young adults up to age 26 became eligible to be covered on a parent's health insurance plan. So that was really awesome too. The choice of providers and plans expanded, and then again, access to those emergency services and participation in treatment decisions became more of a focus, so care became more patient-centric. And then also they expanded these provisions to include fair, fast, and objective review of complaints. So there was a lot of good things that came from the ACA consumer protections that were added. in addition to that patient bill of rights. And you're going to want to make sure you know all of those, because I'm pretty sure there's probably test questions on those. Just throwing that out there. All right, so that wraps up Chapter 3. I was trying to breeze through that in under half an hour, and I beat it by 15 whole seconds. If you have any questions for me, let me know. Thanks, everyone.